Okay, okay. A very good morning to everyone gathered. Arun, continue. Okay, fine. Okay, a very good morning to. On content. A very good morning to everyone gathered Arun here for the hybrid webinar. On behalf of Tiruvannamalai OG Society and TNF OG, I extend my warm welcome to all the faculties and delegates for academic session on RH isoimmunization. RH negative pregnancy is a most important and a pertinent topic which needs careful vigilance from the index as well as the subsequent pregnancies. And also the diagnosis and the management of RH sensitization has undergone many recent updates. So today we have our eminent speakers to give us an insight into the RH sensitization and the practical aspects in managing the RH negative pregnancies. Before moving on to the session, I would like to call upon our President, Tiruvannamalai OG Society, to give Dr. Radha ma'am to give a welcome address, followed by Tamithai Valthu and lightning of the Kuthuvilakku.
Good morning, everybody. Happy Mother's Day to all, men and women equally. Because here it's the men who make the women mothers. It's an honor and privilege to invite all the delegates online and offline to this CME. It's a very happy day to all of us. I welcome Dr. Sasikala, Professor and HOD, Arupade Vidu Medical College. She's an eminent teacher among all the OGians. All students love her. They just worship her in her subject. I welcome you, ma'am. It's a great pleasure that you have come all the way from Puducherry to Tiruvannamalai. I welcome Dr. Sarmati, Assistant Professor, Arupade Vidu Medical College. I invite Dr. Shruti, PGOG, Government Tiruvannamalai Medical College. We want to inspire the budding gynecologists to develop a taste to academics and right from the start to present topics and have a holistic approach towards gynecology and all the practical aspects. I welcome you all. I welcome all the senior gynecologists who have come here. I welcome Dr. Jayalakshmi and Dr. Kalaivani. And I hand over the mic to the master of my ceremony, Dr. Suganya, to take over the thing.
We'll start the session with Tamithai Valthu. Now we'll start a session with lighting the Kuthuvilakku. I welcome all the faculties on board for a lighting ceremony. And also welcome our senior gynecologist, Dr. Jayalakshmi ma'am and Dr. Kalaivani ma'am for lighting the session. And also Dr. Brahmadevi ma'am for lighting the Kuthuvilakku. Moving on to our first session of the day, pathophysiology of Rh negative pregnancy. Our presenter is of first year PG, Tiruvannamalai Medical College. We are happy to announce that we got our PGCs from this year, and she is the first year PG presenting the case today. Dr. R. Shruti, OBG, under the guidance of Professor Dr. Adumai Kandu ma'am. Dr. J. Adumai Kandu ma'am, she is the Associate Professor and Head of Department of Government Tiruvannamalai Medical College and Hospital. She did her undergraduation in Madras Medical College and completed a diploma in Stanley Medical College and a master's in Madras Medical College. She was the recipient of Sir A.L. Mudaliar Prize and Dr. A.L. Mudaliar Medal for Best Outgoing Students in OB-GYN. It's the CV of Dr. Shruti. Dr. Shruti, she is a first year PG of Tiruvannamalai Government Medical College, budding logician. She has graduated from Chengalpattu Medical College in the year 2021 with best outgoing student of the batch. Had a strong record of academic excellence as evidenced by my gold medals in pathology and general surgery, prize exams, honors in biochemistry, physiology, microbiology and pharmacology, and also distinction in anatomy, forensic medicine, ENT and obstetrics and gynecology. The mic is over to you, Shruti. Yes.
A very good morning to one and all present here. A very good morning to one and all present here, and thank you so much, ma'am, for your kind words. And I'd like to thank my professor and HOD, Dr. Arumaikan Madam, for giving me this opportunity, and my mentor, Dr. Bhavani Ma'am, without whom this would not have been possible. My topic for the day is pathophysiology of Rh negative pregnancy. My presentation today is structured with introduction, history, epidemiology, genetics, and the pathophysiology of Rh isoimmunization. There exists 33 human blood group system, of which the two most important are the ABO blood group and the Rh blood group. The ABO has group A, group B, group AB, and group O. Group A has antigen A on the surface and anti-B antibodies in the plasma. Individuals with group B have group antigen B and anti-A antibodies in the plasma. Those with AB blood group have both A and B antigen on the RBC surface and no antibodies in the plasma, while those with blood group O have no A or B antigen but have both A and anti-B antibodies in the plasma. Landsteiner's law states that if an antigen is present on the surface of the RBC, then the corresponding antibody must be absent in the plasma, and vice versa. That is, if an antigen is not present in the RBC, the corresponding antibody must be present in its plasma. There are about 49 described antigens in the Rh blood group, of which the 5 most important are capital D, capital E, capital C, small e, and small c. These antigens are located on the transmembrane proteins of the RBC cell membrane, and their expression starts as early as 38 days of gestation. Of all these antigens, the most important and most immunogenic of them is a capital D antigen. When we say an individual is Rh positive, we mean he or she is D antigen positive, and when we say he is Rh negative, it means they are D antigen negative. The Landsteiner's law does not hold good for the Rh blood group system because there are no naturally occurring anti-D or Rh antibodies in the plasma. So both Rh positive and Rh negative would not have any antibodies until and unless they're sensitized. Now I'd like to take you all through few historic timelines in the Rh isoimmunization. It all started way back in 1939, where a mother who delivered a stillborn baby needed blood transfusion due to blood loss in her delivery. She was transfused with an ABO compatible blood from her husband, but unfortunately she developed an adverse reaction. This led to the thought that there might be something present in the mother's blood that had agglutinated her husband's RBC. This led to the discovery of anti-D antibodies. In 1940, Landsteiner and Werner reported an antibody that reacted with 85% of the human RBCs. This was supposed that the anti-Rh specificity had caused all these incompatibilities. In 1941, Levin found out that more than 90% of the erythroblastosis fetalis cases had mothers with Rh negative blood group and fathers with Rh positive blood group. In 1960, Ronald Finn proposed the concept of anti-D. In 1963, the first ever successful intrauterine transfusion was done by Sir William Lilly. In 1964, the first ever prophylactic anti-D injection was introduced. And in 1968, USA and UK approved the RhoGAM shot among pregnant women. And in 1973, the subsequent research reports stated that by the use of the RhoGAM shot, nearly 50,000 baby lives were saved. So, in 1981, the FDA had approved for full-blown use of the routine anti-D injection for postpartum and antepartum administration. So, the Rh is derived from the word rhesus, which was thought that the rhesus monkey had expressed human blood antigens, but it's a misconception anymore, and the modern transfusion medicine states that there is no term called rhesus anymore. Over to epidemiology, the incidence of Rh isoimmunization is about 6 cases per 1,000 births. The prevalence, the Basque's ethnicity in Spain have the maximum prevalence, which is about 47.2%, next to Caucasians, who are about 15 to 17%, third being Africans, and fourth being Asians. The worldwide prevalence of Rh isoimmunization is 276 per 1 lakh live births. Now I'd like to talk a few points about the Rh antigens and its genetics. These proteins are non-glycosylated transmembrane proteins which have some role in maintaining the structural integrity of the RBC membrane. They might also have role in transport of CO2 and ammonia. So there are 49 antigens as earlier told, of which D, C, E, E and are the most important. The inheritance pattern of the Rh antigens are dominant. There are three most important genes, which are RHD, RHC, and RHAG gene. The RHD gene codes for the main antigen, which is capital D. The RHC gene codes for proteins, which in various combination forms the other C and E genes. And the RHAG gene, which is present along with RHD and RHCE, acts as a co-expressor. As you all can see in this picture, the RHAG gene is a co-expressor, so it's always present along with C, E, and D. For the presence of the capital D antigen, RHD gene protein must be present completely. In case if there is any point mutation or any deletion in the gene, there would be expression of a weak D or a partial D phenotype. Whereas the RHAG gene is responsible for expression of E and C antigens, which depends on the amino acid position in 103 and 226 position. The two most important genetic phenotypes of the D antigen are weak D antigen and Rh null phenotype. A person is said to be weak D antigen when there is a point mutation in the RHD gene, which means there is a reduced expression of the D antigen. So that would result in failure of the RBCs to agglutinate the anti-D reagent. So in normal laboratory testing, this person would test as Rh negative, though he is Rh positive. But however, he can be safely transfused with an Rh positive blood, but if his blood or her blood is transfused to an Rh negative person, this would induce antibody response. An Rh null phenotype. A person is said to be Rh null if his RBCs do not express any of the Rh antigens. It's of two types, regulated type or amorphous type, depending upon the underlying genetic code mutation. As I've told, the Rh antigens are responsible for maintenance of the integrity of the RBC membrane. A Rh null phenotype would experience variable degrees of hemolytic anemias, will have an increased osmotic fragility and degrees of spherocytosis. So a person with Rh null phenotype, if he requires a blood transfusion, he must be given a blood from another Rh null alone. The recently accepted, the current genetic theory is a two loci theory, which is the RHD and the RHCE theory. There exist different nomenclatures for labeling the different Rh antigens. They are the Fisher and Race theory, the Wiener's terminology, the Rosenfield theory, and the ISBT theory. ISBT theory, that is the International Society of Blood Transfusion terminology, is widely followed, where a numerical number is assigned to each antigen and also to the blood group type. For example, Rh blood group is given the prefix of 004 and E antigen of the Rh blood group is given a number of 003. So it combinedly forms a 6-digit code. The ISBT theory is easier because it's purely numerical and it's easy for data processing. Coming over to the pathophysiology. By isoimmunization, we mean when a person develops immunity, that is antibodies on exposure to antigens which are derived from another individual of the same species, we say it to be isoimmunization. In Rh negative pregnancy, isoimmunization occurs when the mother is Rh negative and the fetus is Rh positive. So there are various causes of isoimmunization, which are when there is a mismatched blood transfusion, when there is feto-maternal hemorrhage, that is during a delivery, ectopic pregnancy, during abortions, or during invasive procedures like chorionic villus sampling, amniocentesis, during antepartum hemorrhages like placenta previa, abruptio placenta, during an external cephalic version, if there is an intrauterine fetal death, and there is a manual removal of placenta, severe fetal reduction, molar pregnancy and evacuation, and also during tattooing with unclean needles. A mother is said to be sensitized when the Rh positive RBC cells enter the maternal circulation through a breach in the placental barrier that would result in production of the IgM antibody. If she produces an IgM antibody, she is said to be sensitized. In a normal pregnancy, about 5% of the fetal cells cross the placenta and enter the maternal circulation in first trimester. By the end of the third trimester, it's nearly 46% of the fetal RBCs entering the maternal circulation. But however, majority of the sensitization takes place during the delivery. Though there is but still only 10 to 15% of them gets sensitized. So the naturally occurring anti-D antibody would stay for lifelong, but the synthetic anti-D antibody has a T half of only about 28 days. So this image shows a normal placental barrier When the placental barrier is intact, the Rh positive cells from the fetus would not cross and enter the maternal circulation. When there is a breach in the barrier, these cells enter the maternal circulation and it will stimulate her immunity and she would be sensitized by producing the antibodies. So the aforementioned risk depends on three factors. First, being the volume of feto-maternal hemorrhage. It's been reported that as less as 0.1 ml of blood could sensitize the mother. The second, being the extent of maternal immune response. 30 to 35% of Rh negative mother, no matter what, with how much ever volume of blood they be sensitized, they are called as non-responders. They do not produce an immunological response and they do not mount an immunity to the Rh positive cells. And third, being the presence of a concurrent ABO incompatibility. So the presence of an ABO incompatibility gives a protective role. This is possible especially when the mother is of blood group O and the father is of A, B or AB. This happens because the mother being of blood group O will have a naturally occurring anti-A and anti-B antibody in her blood. So when the fetus RBC cells enter the maternal circulation, due to the pre-existing antibodies, the RBC cells get coated up and this prevents her from getting sensitized. So all that I have talked till now happens in an index pregnancy or in the first pregnancy. While in the subsequent pregnancy, the mother's immunity would be robust and she would produce a more faster immune response. So the immunity which is produced in the secondary immune response is of IgG type, which is capable of crossing the placenta. The IgG immunity from the mother crosses the placenta and enters the fetal circulation and would cause lysis of the fetal RBCs, producing fetal anemia. The heme which is formed is converted to bilirubin by metabolism and there is fetal hyperbilirubinemia. Though there is fetal hyperbilirubinemia, which is neurotoxic, the baby will not develop kernicterus because it's cleared by the maternal placenta and the liver of the mother. This would result, the hemolysis would result in extramedullary erythropoiesis, which would result in production of immature erythroblasts. All this happens because the rate of destruction exceeds the rate of production. So there is a severe anemia, so there will be more demand on production of RBCs, which is compensated by hepatosplenomegaly, that is by RBC production in the extramedullary sites. When the anemia gets severe, the baby develops heart failure, which is manifested as ascites, edema, and pericardial effusion. All this is together called as erythroblastosis fetalis. And finally, hydrops fetalis, that is the heart failure which develops when the hematocrit falls below 15%, resulting in fetal death. The image represents what happens in the first pregnancy. During a feto-maternal hemorrhage, the positive RBC cells enter the maternal circulation and it would produce an immunity, and in her subsequent pregnancies, these antibodies would cross the placenta and enter the fetus and would cause lysis of RBC, fetal anemia, erythroblastosis fetalis, and hydrops eventually. So this is an image showing a baby with hydrops having scalp edema, pericardial effusion, pleural effusion, ascites, and skin edema. Conventionally, it was thought that the first or the index pregnancy always escapes the Rh isoimmunization, but the grandmother theory disproves this. It explains that even a primary gravida can mount an immune response. This is when, if the fetus is Rh negative and the mother is Rh positive, the fetus gets exposed in utero to the Rh positive maternal cells due to transplacental bleed and would mount a response. And this would stay as a permanent memory in her. And when the baby is delivered and she develops into a woman of reproductive age group, and when she conceives and becomes pregnant, and when she is Rh negative and her fetus is Rh positive, when the fetal blood cells entered her circulation during the first pregnancy, her immune response would remember this and she would mount a secondary immune response now. So grandmother theory states that even a primary gravida can mount a Rh incompatibility. So I would like to close my presentation with a question: can both Rh negative parents beget Rh positive baby? This is possible in case of weak D or partial D phenotypes. Weak D or partial D phenotypes, they do not test positive in normal routine laboratory. So in that case, a father being weak D or partial D would be tested as negative. So both parents being Rh negative, but the fetus would be born with Rh positive phenotype. Thank you.
Thank you, Shruti, for taking us through the history, genetics, and brushing our knowledge on the pathophysiology of the Rh sensitization. Now I request Palemani ma'am to give a certificate and memento for preparation. Thank you, ma'am, and thank you, Shruti. Now our second session will be case scenarios and how to crack the difficult situation. Now I call upon our second speaker, Dr. K. Sharumati ma'am. Dr. K. Sharumati, she finished her undergraduation in Chengalpet Medical College. And an MS in Institute of Postgraduate Medical Education and Research, Kolkata, and DNB OBG in 2021. She finished her 1-year residency in Kharagpur SDM Hospital, West Bengal, and currently working as an assistant professor in Department of OBG, Albade Leader Medical College. She was also a gold medalist in obstetrics and gynecology in MBBS. She has honors and 3 distinctions in her MBBS undergraduation, and also medalist in OBG in MS obstetrics and gynecology. Now the podium is yours, ma'am.
Yeah, just I'll share screen. This one, no? Yes. Laptop lo தெரியுதா? A very good morning to everyone present here, and thanks for the warm welcome, ma'am. Today I'm going to discuss about the management of a non-immunized Rh negative pregnancy. So the first case scenario here is a 24-year-old primary gravida was referred from a nearby PHC with 10 weeks of pregnancy. Her booking investigation showed that her blood grouping was B negative and her husband's blood group was O positive. So indirect Coombs test was done for her and it was found to be negative. So this is a case of a non-immunized Rh negative pregnancy. So how should we receive this patient? What are the histories and investigations which we should do for this patient? The most important thing is whenever any Rh negative pregnant patient comes to the OPD, first ask for any previous history of any blood product transfusion, which includes both whole blood or platelet transfusion. Ask for previous history of miscarriages and ectopic pregnancy, because many times patients forget to tell about the history of miscarriage if it has happened some 2 or 3 years back. So ask for this specific history. And next most important thing which we should do is assign her gestational age accurately. So for example, the patient might have had irregular menstrual periods. So ascertain that her LMB was regular, she is able to remember her LMB properly, and get a dating scan done to update her pregnancy, so that because in Rh negative pregnancy, we don't want her to go beyond the due date. So these are the potentially sensitizing events which increases the risk of fetal-maternal hemorrhage, which Dr. Shruti has already told us. Here we can see that the maximum risk is during delivery. There is 45% increased risk of fetal-maternal hemorrhage. And also with ruptured ectopic pregnancy, risk of fetal-maternal hemorrhage is 24%. So what we do is we always remember that during antenatal period and postpartum we give anti-D. But even during the other maneuvers, we should remember that we have to administer anti-D to these patients. So whenever any potentially sensitizing event occurs less than 20 weeks, we have to give her 50 microgram of anti-D. Whereas if it occurs more than 20 weeks, we have to administer 100 microgram. For example, if a patient is having APH with recurrent bleeding, then we have to administer 100 microgram, which is equivalent to 500 international units at 6 weekly intervals. And we should also quantify the fetal-maternal hemorrhage. So our patient, which we were discussing about, her husband was Rh positive. If her husband is negative, then it is a normal ANC, then we don't have to give extra care. But whereas if her husband is positive, Rh positive, the next thing which we would like to do is an indirect Coombs test. So what is this Coombs test? So there are two types of Coombs test. One is direct Coombs test and the other is indirect Coombs test. ICT we do in maternal serum. So it is going to detect the antibodies which are going to be freely floating in her blood, which means she is already immunized. Whereas direct Coombs test is done in the fetal blood to determine if the fetal blood cells are already been attacked by the mother's antibodies. So this is how we do an indirect Coombs test. So we take the mother's plasma, and the plasma is going to contain only the antibodies. We are going to add the reagent erythrocytes, which are O positive RBCs. So once we incubate both together, an antigen antibody reaction is formed between the maternal antibodies and the donor RBCs. So next step, we are going to add this Coombs reagent or the anti-human immunoglobulin. So if the mother is already having the antibodies, agglutination is going to take place. Whereas in a direct Coombs test, it is a single step test. Already the fetal RBCs, if it is baby is going to be attacked with the antibodies, it is going to be coated by the antigen. So if I'm adding the Coombs reagent, there is going to be agglutination. So whenever there is agglutination in the mother, it means that she is immunized. And whenever DCT is going to be positive in the baby, it means the fetal RBCs have already started getting hemolyzed. So whenever a mother comes to us at booking visit, we get an ICT done. So if it is negative, we are going to repeat the indirect Coombs test at 28 weeks. Again, if it is negative, we have to administer her anti-D injection. This is only called as routine antenatal administration of anti-D prophylaxis or RAADP. So according to ACOG guidelines, we give only a single dose of anti-D of 300 microgram if at 28 weeks a woman is going to be ICT negative, and this is what we follow in India also. Because giving a single dose, the patient is going to have better adherence and we are not going to miss anything later in the follow-up. So the asymptomatic fetal-maternal hemorrhage during the third trimester is 2%, and when we administer this anti-D, it is going to reduce to as low as 0.2%. So in UK, they are following the double dose regimen. So there they give 100 microgram at 28 weeks, and again they do a repeat an ICT at 34 weeks. If it is negative, then they repeat another dose of 100 microgram. So the risk of allo-immunization in an Rh negative pregnancy. So as the previous presenter told very clearly, why Rh incompatibility or ABO incompatibility is going to be helpful. So whenever the mother and the fetus are going to be ABO compatible, the risk of allo-immunization is 16%. That is 2% of these women will be immunized at the time of delivery, 7% by the next 6 months, and 7% will remain sensibilized, which means their antibodies are going to be present at a very low level. And when they become pregnant the next time, there is going to be a very heightened immune response, and she is going to attack the baby if the baby is going to be Rh positive at a very early trimester. So if the mother and fetus are Rh ABO incompatible, then the risk of allo-immunization is only 2%. If we administer any patient postpartum anti-D, then the risk is only 0.5 to 1.8%. Whereas if I give both antepartum and postpartum anti-D, the risk reduces to as low as 0.1 to 2.2%. So this is a mechanism of action of anti-D. So you can see in the picture that this is a fetal RBC. It is Rh positive. So when it enters the maternal circulation, this anti-D is going to coat these RBCs, and immediately the phagocyte is going to clear up all these cells in the spleen. So this is what is a mechanism of action of anti-D. So 300 microgram dose which we give in the antenatal period, it is going to give protection against 15 ml of fetal RBCs or 30 ml of fetal blood. The half-life of anti-D is only 23 days. We should give it as an IM injection in the deltoid muscle or in the anterolateral aspect of thigh, and never give anti-D injections in the gluteal region. So if suppose a patient is affluent and she is affordable, we can avoid all these investigations, and what we can do is determine whether the baby is going to be Rh positive or negative. So using cell-free fetal DNA we can do this, and if the baby is going to be Rh negative, then there is no need of any more follow-ups in that pregnancy. Whereas in 40% of patients, they carry an Rh negative fetus. That is why we don't go for this costlier investigation. Whereas if a patient is affordable, you can do it. Timing of delivery. So this patient was a preemie. I have already given an ICT done at ICT at 28 weeks. It was negative. So we have administered her anti-D. So I am going to time her delivery at 40 weeks of gestation. So we should not allow her to go beyond due date. We are going to induce a labor. If there is any obstetric contraindication, then we are going to do an LSCS. If not, we are going to do induction of labor. If Bishop score is less than 6, we can give prostaglandin gel. If it is more than 6, then we can start amniotomy and start her on oxytocin drip. So during labor, what we have to take care is that continuous electronic fetal monitoring should be done. Any unnecessary instrumentation should be avoided during labor. All the maneuvers which we should do in labor should be very gentle. We should avoid use of methotrexate because it increases the quantity of fetal-maternal hemorrhage, and we should also avoid manual removal of placenta. Earlier they said that early cord clamping should be done, but nowadays they say that we can do delayed cord clamping, provided we have to keep the cord as long as possible, at least 10 to 15 centimeter, because the baby may need exchange transfusion. So at birth, we take 5 ml of cord blood for analysis. We do serum bilirubin testing, hemoglobin, hematocrit level, direct Coombs test, and blood grouping and typing. So if my baby is going to be Rh positive, then we have to administer the mother 300 micrograms of anti-D injection as early as possible within 72 hours of delivery. So in some studies, it has been shown that 99% of women have fetal-maternal hemorrhage less than 4 ml. So this 300 microgram is a very high dose, it is sufficient. But sometimes patient may have, example in twin deliveries or during PPH or an abruption, there can be increased fetal-maternal hemorrhage. So if you are not going to quantify fetal-maternal hemorrhage in these cases, then these patients are given less protection, and next pregnancy she can be immunized. So whenever the fetal-maternal hemorrhage is more than 10 ml, then we have to add additional anti-D, and it can be given as an IM injection at separate sites every 12 hours. So this quantification can be done using the help of KB test or using flow cytometer. Flow cytometers are not usually available in all these hospital setups. It is very expensive. But KB test is Kleehorn Betke's test is very inexpensive. It can be done in all the laboratories. So whenever you suspect that the quantity of fetal-maternal hemorrhage is more, so please advise KB test for those patients. So the scenario 2 is, for example, a patient has come for MTP. You never saw the blood group of the patient, and you have done a surgical termination of pregnancy, and she has gone home, and later you realize that her blood group is Rh negative. So in those cases, what is to be done? You have already discharged the patient. So in those cases, they say that up to 13 days, it is going to provide partial to complete protection. And even as late as 28 days also, we can give anti-D, but the protection offered is going to be very low. So the next scenario is, for example, with the changes in the culture and everything, there is a possibility that the mother might not know who is the father, or the father might have passed away. So in those situations, we can check the indirect Coombs test. If it is negative, give her anti-D prophylaxis antenatally. Or if she is affordable, then we can go for self-repeated DNA testing. If the baby is Rh positive, then we can continue monitoring for that pregnancy. The scenario 4 is about the weakly Rh positive, previously called as DUE positive. So these patients, even though they are weakly Rh positive, they do not form anti-D antibodies. So they do not require any antenatal anti-D prophylaxis. But in case this same patient is going to undergo PPH, then she will need to be transfused with Rh negative blood. Whenever she is going to be a donor for someone, you should treat her as Rh positive, and she is going to be a recipient, you should treat her as Rh negative. So this is a take-home point for today. For non-immunized Rh negative pregnancy, give anti-D at 28 weeks and postpartum anti-D within 72 hours. And we all follow this. But what we as clinicians should remember is, whenever any patient comes for MTP, let it be medical or surgical, we should have the habit of documenting the blood group and Rh typing in a ticket. And then only we are supposed to send the patient. And it is always desirable to check for the quantity of fetal-maternal hemorrhage after delivery in almost all the cases. Anti-D should be given as an IM injection, and the cord should be kept long during delivery. Thank you all.
For giving us a very basic and practical first topic chart negative pregnancy. Hello. Thank you, ma'am, for giving us a very basic and practical method to approach Rh negative pregnancy. Now I call upon Dr. Jayalakshmi ma'am to present the memento and certificate to Dr. Charumathi. Thank you, ma'am. Now we move on to our next session. We feel very overwhelmed to welcome Dr. Sasikala ma'am to share a discussion on the case scenarios and how to crack the difficult situation. Dr. Sasikala ma'am. Dr. Sasikala ma'am, she is the chief and the head of Department of Albarai Medical College and Hospital. She graduated in Madurai Medical College, did her undergraduation and post-graduation there, and associate professor and assistant professor in Government Rajaji Hospital, Madurai, and she retired as professor and HOD of OB-GYN in Government Lady Medical College. She was a present professor and HOD of OG in Sri Manipula Vinayagar Medical College and Hospital, and also at present she is working as a professor and HOD in Albarai Medical College. She was the UG and PG examiner in various states and member of PG Board of Studies in University. Welcome, ma'am.
Welcome. Thank you. Yes, good. Just this. I have to press. Thank you. Good afternoon to all. Happy Women's Day. Okay, I really want to thank Dr. Radha for inviting me for this CME, and I'm privileged to be the part of the CME. Today, having addressed about the basic pathophysiology and the management of a non-immunized Rh negative pregnancy, I want to get into the depth. Am I audible? I want to get into the depth of this. Yes, ma'am. The screen is being shared.
Slides are not sharing.
Stop share.
Yes, this is the first.
Correct.
I want to discuss about the depth of the subject by putting some case scenarios. The first case scenario goes like this. Mrs. X, she is 28 years old. She is a second gravida, para 1, alive 1. She was an Rh negative pregnancy and the spouse is positive. The first pregnancy, she was a booked case at Kadalur Private Hospital. As she has been diagnosed to be Rh negative, they have done an ICT there. It was found to be negative, but no antenatal prophylaxis has been given there. And the lady has developed a gestational hypertension and she was on labetalol for 6 weeks. At 37 weeks of gestation, she has undergone an emergency cesarean section at that hospital as she has landed with a painful bleeding and they have diagnosed it is a case of an abruptio. So the case was taken up for a gestational hypertension with abruptio placenta, and immediately on the second day after the surgery, she has been given 300 micrograms of anti-immunoglobulin as the baby happens to be Rh positive. The baby is doing well. It is 3 years old. And after that, She has conceived some 2.5 years after the first childbirth, and she has gone to the same hospital for the checkup, and they have done an ICT there and it was found to be negative. And this time, the obstetrician has sensitized her regarding the antenatal prophylaxis for which the lady consented. And this private practitioner, the obstetrician, she has clearly written in the operative notes that the retroplacental clots was 100 grams during the cesarean section, and the blood was not given during surgery. And at the time of booking for the second pregnancy, the ICT was negative. And when she repeated it at 22 weeks of gestation, the ICT was positive, and she has been referred to us as a case of a post-cesarean pregnancy with an ICT positive at 22 weeks of gestation, as we do have a competent fetal therapist, fetal medicine specialist who is coming as a visiting professor to our hospital. Why ICT is positive in the present pregnancy in spite of giving an postnatal prophylaxis? As a routine, after the delivery, we are giving, without quantifying the feto-maternal hemorrhage, we are giving 300 micrograms of anti-immunoglobulin. In 98% of the cases, this will suffice. It will prevent the 12 ml, at most 15 ml of fetal RBCs, which is equivalent to 30 ml of fetal whole blood. But 1 to 2% of the cases, as in the case of an abruptio or a placenta previa or a multiple pregnancy, or it could have been a retained placenta necessitating a manual removal. So only in 1 to 2% of the cases where we anticipate a large amount of feto-maternal hemorrhage, this amount of anti-immunoglobulin which you have given will not suffice to deal with this feto-maternal hemorrhage, thereby resulting in isoimmunization. As my assistant has already mentioned, when an RH negative pregnancy carrying an RH positive fetus, if she has not been given either an antenatal or a postnatal prophylaxis, the chances, and moreover, she is O negative, the husband may be AB or ABO, AB. In the presence of ABO incompatibility, the chances of isoimmunization will be just 2%. If it happens to be an ABO compatible, the chances of isoimmunization will become 16%. 2% of them will become isoimmunized during the present pregnancy, that pregnancy, index pregnancy itself. 6% of them will become positive at the end of 6 months, and the remaining 6 to 7%, when they become pregnant for the second time, when they have been exposed to a further bolus of RH erythrocytes, which you call as a sensibilized. That is the reason that the ICT is positive, or it could have been a mild feto-maternal hemorrhage that could have occurred in the present pregnancy. That could also be a cause. The ICT was positive. Now, as my previous speaker has told, there is a method to quantify the feto-maternal hemorrhage. The simple test that can be done is a Rosette test. A Rosette test is a qualitative test. It is not able to quantify the feto-maternal hemorrhage. You are going to take just a maternal blood sample, a peripheral smear, put a drop of anti-immunoglobulin, the fetal erythrocytes which are positive, the antibodies which we have added will cling to those positive antigen site. Now, when you are going to add a positive erythrocytes to that, it will go and adhere to that positive erythrocytes with the adherent antibodies, and it will appear just like a rose petals when you are looking it under the microscope. This is called as a Rosette test, and this is only a qualitative test. You can't quantify the feto-maternal hemorrhage. By looking at that, you can find out, okay, large amount of fetal erythrocytes has entered the maternal circulation, so better to quantify the feto-maternal hemorrhage. Okay, you may be working in a setup where you don't have a facilities to do a Klehoyer Betke test, and flow cytometry is available only in 2 centers in Chennai, which we people, it is cost effective, it is not affordable, although it is more sensitive. What best you can do? Do an indirect Coombs test after the postnatal administration. If the indirect Coombs test comes as positive, the dose which you have given is sufficient. If the indirect Coombs test comes as negative, then administer one more dose of anti-D immunoglobulin. This is a practical aspect. So after the administration, if you have an intuition, the amount of anti-D immunoglobulin which I have given may not suffice to deal with a large amount of fetal-maternal hemorrhage, just do an ICT. If the ICT comes as positive, then the dose which you have given is sufficient. What does it mean? Because the antibodies would have gone and adhered to the positive erythrocytes. Even in spite of adherence, there are some amount of free antibodies which is present in the maternal serum even after tackling the fetal erythrocytes, which will come as a positive ICT. So if a positive ICT comes as a report, you can say, okay, the amount of anti-D immunoglobulin which I have given is sufficient. That is a practical aspect. Now, this has already been done. How to quantification of Klehoyer Betke test? It is based on the principle that the fetal erythrocytes containing the fetal hemoglobin will be lysed when you are putting the acid, but the adult erythrocytes will be lysed by the acid, whereas the fetal erythrocytes containing the fetal hemoglobin is resistant to the action of the acid. So you are going to make a peripheral smear, put it in an acid bath, put in a strain, and then you visualize it under the microscope. The adult erythrocytes, because of the lysed hemoglobin, they will appear as a ghost cell, whereas the fetal erythrocytes will appear as dark refractile bodies, and you're going to count the number of fetal erythrocytes per 1,000 cells or 2,000 cells, and this formula will hold you good to find out what is the amount of fetal-maternal hemorrhage. And when it comes at 60 ml, you all know 30 ml of whole blood of fetal blood, when it enters the maternal circulation, it can be tackled by giving 300 micrograms. Now, when you're going to quantify and it comes at 60 ml, she needs to be given 2 ampules of anti-D immunoglobulin. Okay, this can be. Now, how to proceed with the present case? Now, she has come to me with an ICT positive. The girl is asking me, ma'am, if the ICT is positive, does it mean the fetus in utero will be affected? What should be my answer? It may or may not be affected, because if the husband happens to be a heterozygous positive, which means there is only one D antigen which is inherited from either the father or the mother, the other one doesn't have. If the father happens to be a heterozygous positive, there is a chance that 50% of the children will be negative and 50% will be positive. But if the husband happens to be homozygous positive, then 100% of the fetus in utero will be definitely affected. Then comes your question of determining the zygosity of the spouse, whether he is heterozygous positive or a homozygous positive. And when he is heterozygous positive, the fetus in utero could be Rh negative. Then I should determine what is the grouping and typing of the fetus in utero. Previously, there were all this invasive technique of doing this amniocentesis and chordocentesis, and then we determine the fetal group. Now everything has gone. It is a non-invasive test. By just drawing the maternal blood, I can find out what is the grouping and typing of the fetus in utero. It can be very well found out from the end of the first trimester itself. Only thing, it is cost effective. It is a cell-free fetal DNA test, and it costs anything about 18,000 to 20,000. Yes, it is available. Even in Pondicherry, it is available, and in Chennai, it is also available. It is cost effective. But you may ask me, ma'am, the husband is not willing to find out whether he is homozygous or heterozygous. And I'm not in a position to either go to Chennai or some other metropolitan cities to find out the cell-free fetal DNA, which is not possible. What is the cheapest thing that can be done? You can monitor the fetus by doing an ultrasound and a Doppler. Okay, if you're not able to find out, the ultrasound and the Doppler is available in all centers. Then you can monitor the fetus to find out whether there is any signs of anemia, or if there is, what is the Doppler of the middle cerebral artery. Now, why the middle cerebral artery peak systolic velocity should rise? Now, you all know the placenta is not a watertight compartment. The erythrocytes from the fetus, it crosses the placenta right from the first trimester and it enters the mother. In the same way, the maternal antibodies, if it happens to be an IgG, it crosses the placenta and it comes to the fetus. Okay, so what happens? How to monitor? Now, when these antibodies, they cross the placental barrier and enters the fetus. If the fetus happens to be Rh positive, it causes hemolysis of the RBCs. So the fetus is put under a hemolytic anemia. So it is put under a hypoxic insult. To compensate for the anemia, you all know the first, to start with, the RBCs are produced within the yolk sac. At the 4th month in the fetus, the liver takes over, and only in the 7th month, the bone marrow comes and produces the erythrocytes in the fetus. So what happens? The extramedullary sites for the production of the RBCs, such as the liver and the spleen, they undergo megaly, hepatomegaly, splenomegaly, and the placenta will increase in size so as to trap whatever amount of oxygen that is present in the mother. So the placenta will undergo placentomegaly. Then the fetus is not, supposing it is put under a hypoxic insult, what it does? It shunts the blood to the brain to compensate for the hypoxia. That is called as the brain sparing effect. And when the fetus is under anemia, it tries to improve its cardiac output. So because of the increased cardiac output and low viscosity, there is an increase in the middle cerebral artery peak systolic velocity. And this peak systolic velocity is measured in centimeters per second, and there is an applicator which will change it into multiples of median. So, the monitoring of the middle cerebral artery peak systolic velocity is the investigation of choice to find out the fetal anemia. Okay, that is the point which I want to emphasize. The fetal middle cerebral artery peak systolic velocity, when it crosses 1.5 multiples of median, it indicates that the fetus in utero is under severe anemia and it needs an intrauterine transfusion. In this, what is the newer concept? Here, the lady has come to us with a indirect Coombs test is positive, and it was positive 1 in 8 dilutions. Okay. And previously we used to say, repeat the titer once in 4 weeks till it reaches the critical titer. At this critical titer only, we expect that the fetus in utero may be affected. Now the concept has changed. If the indirect Coombs test comes as positive, and if the dilution is 1 in 8, you have to refer the patient to the fetal medicine specialist. Don't wait for the critical level to achieve, because they say the severe of hemolysis does not correlate with your antibody titers. Even a fetus with a 1 in 16 dilution may develop eye drops, and in 1 in 256 may not develop eye drops. It all depends upon the immunological behavior of the fetus, and also it depends upon the strength of the antibodies. So if the ICT is positive, refer the patient to the fetal medicine specialist. Your attention must be diverted from the mother to the fetus in utero if the ICT is positive. You have to monitor the fetus for the signs of impending failure, and it is the sonologist's duty to pick up the fetus if it happens to be severely anemic and then plan for an intrauterine transfusion. Yes, we do have a competent fetal medicine specialist in Pondicherry who does intrauterine transfusion. We have referred the patient to him. Okay, and then the patient was at follow-up with him at about 28 weeks and 3 days. When the middle cerebral artery PSV reached 1.5 millimoles of median, he has planned an intrauterine transfusion and it was given there. And just a few words for the benefit of the postgraduates. How to do an intrauterine transfusion? You have to have only a O negative blood. This blood has to be cross-matched with that of the mother. It should be a fresh blood. It should not be a stored blood. And it should be irradiated. Why? They are subjecting that to 1500. It should be irradiated to become leukocyte free and to prevent host versus graft rejection. And the target hematocrit which we are going to plan, it should be anything about 40 to 50%, but the blood Paxil which we are going to transfuse should be anything between 70 to 80% hematocrit. A simple formula to find out how much of the blood to be transfused is weight of the fetus in grams as per ultrasound into 0.02 for every 10% rise in the hematocrit. Let me say it is 30%. If I want to rise it to 40%, for every 10% rise, the sonologist will find out the weight of the fetus in grams. So the weight of the fetus in grams multiplied by 0.02 for every 10% rise in the hematocrit value. Okay. It is usually done round about 20 weeks. It can be very well done up to 34 or 35 weeks of gestation. After 35 weeks, it is not being done. And what is the route we are going to choose? It is the umbilical vein or intrahepatic portion of the portal vein. That is the ductus venosus. Our fetal medicine specialist, he preferred the ductus venosus. He said, ma'am, when we are negotiating the needle into the ductus venosus, even if the needle comes out, it will be in the peritoneal cavity. Sometimes if you put it in the umbilical vein, it can cause a hematoma of the umbilical cord resulting in a bradycardia. So he preferred the ductus venosus of the intrahepatic portion of the portal vein. And it is done in the theatre under aseptic precautions, under ultrasound guidance. Okay, now the first thing, the baby has to be paralyzed. We have to inject pencodium to paralyze the fetus, and a spinal needle anything between 20 to 22 gauge is inserted into the umbilical vein and the fetal blood is drawn. We are going to find out the hemoglobin, the hematocrit, the blood grouping and RH typing. We are going to do even a bilirubin level and then the reticulocyte count. Why I am specifically saying a blood grouping and RH typing? When you have given one or two transfusions and when you are going to deliver the baby's blood group will come only as O negative. Only after 4 or 5 months, the baby's blood group, the original blood group is come. So at the time of intrauterine transfusion, we have to determine the grouping and typing of the fetus and it should be recorded in the maternal case sheet. Because when we are going to give 2 or 3 intrauterine transfusion and when you are going to deliver the baby and when you are going to draw the blood from the cord, as soon as the baby is born, it will come only as O negative because we have already given the baby O negative blood. So the correct blood will come, supposing if the baby happens to be B positive, the correct blood grouping of the fetus you will be able to get only after 4 or 5 months. Okay. And the rate of transfusion should be anything about 2 ml per minute. Okay. This is the method by which you are doing. There is a video. If time permits, I can put it. It has been given by my fetal medicine specialist. Okay. And you should monitor the fetus 24 hours after the IUT. And supposing My idea is to get at least 40 to 50% of the hematocrit at the end of the intrauterine transfusion. Let me say I have made it as 45. At the end of the transfusion, I have drawn the blood and I have estimated the hematocrit. It has come as 45. Okay, I'm happy. Now, when I'm going to plan the second transfusion, she is just 28 weeks. The baby cannot be delivered. I have to drag on the pregnancy up to 34 or 35 weeks so that if I deliver, the baby will have a good extrauterine survival. I don't want to put both prematurity as well as this RH incompatibility. So, the rate of fall of the hematocrit will be 1% per day. If it is 45% today I have done, tomorrow it will become 44% and 43, so that I can plan my second transfusion after a period of 15 days or so. Okay, I have planned it and I'm going to give a second transfusion. After the second transfusion, the rate of fall of the hematocrit will be only 0.6 to 0.8. There will be a slow in the fall in the platelet count. Why? Because I've given the transfusion, the bone marrow is being suppressed. Okay, so the rate of fall of the hematocrit will not be as much as when I have given the first time intrauterine transfusion. It will be less than that. So, in some of the sonologists, they say, ma'am, after you have given one intrauterine transfusion, you cannot rely on the middle cerebral artery PSV because you have already given the intrauterine transfusion. But some of them are of the opinion, instead of keeping 1.5 multiples of median, if you are going to keep it as 1.7 multiples of median for a subsequent transfusion, that will hold good. But the fetal medicine specialists are saying, if you're going to keep 1.7 multiples of median, you may miss out a fraction of the anemic fetus. So better to rely on the rate of fall of the hematocrit. That is a matter of controversy regarding 1.7. Okay. And at 30 weeks for this lady, we have given a second transfusion. At 33 weeks and 4 days, a third intrauterine transfusion was given and the lady was taken up for repeat cesarean section with sterilization and 2nd of May in our hospital after a course of steroids. And the baby's weight is just 2.3 kg. It is doing fine. And the cord blood hemoglobin, which we have collected. Okay. And regarding the neonatal care, don't think that your problem ends after the delivery of the mother. The baby must be put under your care, under the care of the neonatologist for a period of at least 4 to 5 months. You know, however severe the hemolysis may be, the baby that is born will not be jaundiced or icteric at the time of birth because the excess bilirubin that is formed due to hemolysis will cross the placental barrier. The maternal liver will conjugate the excess bilirubin and the mother will excrete the bilirubin. So, however severe the hemolysis may be, the fetus will not be icteric or jaundice at the time of birth. Only when the connection between the mother and the fetus is severed, slowly the jaundice will develop within the first 24 hours after delivery. Don't imagine that the fetus will be icteric at the time of birth. Okay, there are a few indications. Neonatal care should be by the phototherapy or by the exchange transfusion. When you put the patient under phototherapy, we have got a double surface phototherapy and we have got a blue light and we have got a Billy blanket also in our NICU. So it will be, I think with this intense phototherapy, our baby will come down and come up, and I hope so. It may not need any exchange transfusion. Okay, the Billy blanket is the one where we are going to cover the baby with an optic fibers. It will transmit the light of the desired wavelength. Okay, this is now coming to the case scenario 2. The lady, she is a third gravida with para 1, alive 1 and abortion 1. First, it happened to be a spontaneous miscarriage at 12 weeks of gestational age, and she had an instrumentation done, but somehow the anti-D immunoglobulin was not given. And second pregnancy, she has landed in Pondicherry Institute of Medical Sciences, and there the ICT was positive, and they have given thrice intrauterine transfusion and they have delivered the baby by inactive LSCS. The baby is 2 years old. Now that the lady comes to us having missed the periods, she is just 2 months of amenorrhea. The third is the current pregnancy. In this case, you need not do an ICT. ICT has got no value because already she has been isoimmunized and then, sorry, the battery is running low. So, it has to be connected. So already she is an isoimmunized pregnancy. So the question of ICT doesn't come here. Don't, for the purpose of the PGs, I'm saying no role for an ICT in an already isoimmunized pregnancy because it was already reached the critical value and the girl gives you a history that she has undergone thrice intrauterine transfusion at a private hospital. Okay, what best you can do? You can monitor the fetus right from 16 to 18 weeks of gestation to find out the signs of anemia. And as I've already told you, if you're going to do a cell-free fetal DNA and if the baby happens to be Rh negative, no one in the world will be happier than us. The obstetrician and the patient will be very happy to deal with her. Okay. By God's grace, we wish that should happen. Okay. So no meaning of doing an ICT in an already isoimmunized pregnancy, and you're going to monitor the baby fetus in utero by doing an ultrasound as well as by the Doppler. Okay, and the earlier period that you can do the intrauterine transfusion is anything after 18 weeks. Now that they are saying up to 34 or 35 weeks, 34 weeks you can do an ICT and then deliver the baby at 36 or 37 weeks instead of hurriedly delivering at 34 weeks. Okay, this case scenario 3, a 24 years old primi gravida Rh negative with a spouse positive at 10 weeks of gestation with an ICT positive. Okay, we elicited the history. She doesn't give any history of blood transfusion. There was no previous history of miscarriage. She happened to be my neighbor, and when we provoked her, she gave me the history that she had been hospitalized for a dengue fever and she had platelet transfusion. So have it in your mind, not only the blood components can also give rise to isoimmunization. And lastly, it could be, as the postgraduate has explained, it could be even a grandmother theory. Okay. Okay, thank you for the patient hearing, ma.
It was a pleasure listening to you, ma'am. Thank you for enforcing the importance of prophylaxis in the antenatal period and also the need for quantification of fetal-maternal hemorrhage. Postpartum in high-risk pregnancies and also valid points into practical aspects in management on sensitized pregnancies. Now I request our Secretary, Tiruvannamalai OG Society, Dr. Alanendu ma'am, to present us with a memento and certificate for Dr. Sasikala ma'am. Thank you, ma'am. Now we are moving on to the final session of the day, capsule on anti-B. by Dr. Radha Madhavi Madam, the founder and president of Tiruvannamalai OG Society. Dr. Radha Madhavi, founder and president of Tiruvannamalai OG Society. She is the director of Raja Multi-Speciality Hospital and Raja Institute of Paramedical Sciences. Did her undergraduation in Bangalore and post-graduation in the Hasbros and finished a diploma in Nation Board in New Delhi 1995. PG diploma in ultrasound in 2013 to 14, and she was worked as a SR in Pipa Memorial Institute of Oncology, Chengalpattu Medical College. And also she has conducted two annual conferences, GestureCon 2017 and 2018 in Tiruvannamalai Medical College. Over to you, ma'am.
Medium. ಇದನ್ನು AUB. ಇಮೇಲ್ ஒரு நிமிஷம் இல்ல இங்கதான் தெரியும் அங்க தெரியாது இது ஃபைனல் தானே மேம் 11 ஆர்எஸ் உங்களுதா ஓ மேடம் ஏன் மேல பேர் என்ன சொல்லுங்க அது கேட்பீங்க நீங்க பாஸ்வேர்ட் பண்ணி போடுங்க இதை க்ளோஸ் பண்ணிடுங்க மேடம் இல்லப்பா நீங்க இங்க தெரியாது அனுப்பியிருக்கேன் அது ஓப்பன் பண்ணுங்க உங்க மெயில்ல உங்க பிபிக்கு அனுப்பியிருக்கேன் க்ளோஸ் பண்ணிடுங்க இல்ல இது தெரியாது யாருக்குமே இது வந்து இங்க மட்டும் தான் ஷேர் பண்ணவே இல்லை இது சென்ட்ரா தான் இது எக்ஸ்போர்ட் போயிடுச்சு ராங் பாஸ்வேர்ட் இதுக்கு ஒரு நிமிஷம் ஆல்ரெடி டவுன்லோட் வரல தானே
Good afternoon, everybody. Sorry for the technical glitch. It's the first time we are doing a hybrid webinar. And next, is we've had a pathophysiology of all the RH incompatibility as shown in this picture. We have gone through extensively about this. I don't want to keep repeating it. Now, as Madam told, everything to in RH incompatibly, we know that we have to give anti-T and all that. It mostly depends on the feto-maternal hemorrhage and the quantification of the feto-maternal hemorrhage. As we see in this slide, first trimester we have 6.5% feto-maternal hemorrhage, and it's it keeps increasing. In third trimester it is 29%. This is to say we should all use anti-D prophylaxis antenatally. This just goes to enforce that we should give anti-D prophylaxis antenatally also. During delivery, it is almost 76% incidence during delivery. The risk of sensitizing depends on the feto-maternal amount of volume of feto-maternal hemorrhage. If it is more than 5 ml, 65% of them will get sensitized. We have gone in detail about the Kleihauer-Betke test. This is for the quantification. If there is no postpartum prophylaxis, what happens? In first pregnancy, as we already told, grandmother theory can be there. Second pregnancy, RH positive child, we can have this hemolytic disease of the newborn with jaundice, eye drops and all that. Sasikala madam had told very detailedly. Incidence of sensitization is 12% to 16%. The anti-D immunoglobulin is given to a woman to prevent her producing antibodies. Initially, it was extracted from plasma of donors having high circulating levels of anti-D. It was given intramuscularly or sometimes intravenously. Development of anti-D usually are results of feto-maternal hemorrhage. It should be administered, again I want to reinforce, within 72 hours. But as Charumati ma'am told, we can even give until 28 days also. The first trimester, the dose is 50 to 100 micrograms. In all these events, anti-D, in such events like where you expect more hemorrhage to happen, the anti-D should be used as 100 or even 300 micrograms can be given. This is the same slide. Ectopic pregnancy, we usually do not think about giving anti-D, but it is recommended that in ectopic pregnancy also, we should give 50 micrograms, and any surgical procedure, and 19 plus weeks, we should, until 19 plus weeks, we should give 50 micrograms. Anti-D may be omitted when the complete mole is diagnosed with no non-sensitized RH negative mothers, and for partial mole or uncertain diagnosis. But anti-D who are suspected of molar and who have undergone uterine evacuation, we should give anti-D. A minimum of 50 should be administered to all cases with molar pregnancy also. In such cases like APH, abdominal trauma, external version, placenta previa, we have to use a dose of 125 if it is less and more, 300 if it is third trimester and more. What are the guidelines and recommendations telling us? We will follow the American College guidelines, and next I'll tell you about the ICOG guidelines also. If there is a complete miscarriage, we should use 50 or even 120 micrograms. Spontaneous complete and no anti-D, and before 12 weeks, if it is spontaneous miscarriage, I would prefer to give anti-D. I will not, anti-D is not there. Pregnancy termination, anti-D as told 50 or 120. After 12 weeks, I prefer 300. Rupture tubal pregnancy earlier, as I told. For chorionic villus sampling, amniocentesis, ectopic pregnancy, threatened miscarriage, all of them we give anti-D in all the correct doses. It's aimed to prevent sensitization during and after pregnancy. All patients, MTP, medical, surgical, should have knowledge of documentation of their blood group and RH. After all sensitizing events in the first trimester, we give 50 to 100. Mid and late pregnancy, we can give 300 micrograms. Now coming to the type of anti-D we use. Earlier we were using polyclonal, monoclonal. Now we have what is called the recombinant anti-D. Conventionally, anti-D was produced with fractionation of IgG from pooled plasma of RH negative men. Men help us a lot. Immunized with anti-D RBCs. The resultant IgG is polyclonal and referred to as polyclonal anti-D. Now, polyclonal anti-D was derived from immunized humans. The limitations was we needed human donors. They don't donate for their own people. How will they donate for producing anti-D? Limited capacity of production and risk of transmission of viral and prion diseases and periodic shortages. Most of these limitations were addressed by the introduction of monoclonal anti-D manufactured using hybridoma technique. Coming to the comparison between monoclonal and polyclonal anti-D. Monoclonal is greater and consistent. Polyclonal lower inconsistent. Specificity is high. It is mixed. Half-life is 23 days. It's highly purified. High homogeneity. No risk of transmission of any viral diseases. And there is an unlimited supply. We are coming to recombinant anti-D. All of us are using the same thing. The natural successors to hybridoma-derived antibodies are the recombinant DNA-derived antibodies, considering the advances made in technology using antibody manufacture. Developed anti-D IgG antibodies using recombinant DNA technology and genes for anti-D derived from the hybridoma to manufacture monoclonal anti-D immunoglobulins. The antibody genes from this hybridoma were isolated and introduced into Chinese hamster ovarian cells, enabling the cells to express recombinant anti-D. A clinical study was performed. It was to compare recombinant and conventional. Efficacy data. So, coming to polyclonal anti-D versus recombinant, we obviate the need for fetal bovine serum, and it avoids the problems of cell line changes and mutations as observed in hybridoma production and storage, and it provides a better yield. Our anti-D. Initially, in a few years back, we were not using because of the risk of HIV. For so many years, we were not giving anti-D because patients can sue us. Now, with this recombinant, there is no risk of not giving anti-D and all. Anti-D may be a suitable alternative to anti-D preparations in the market for prevention of maternal alloimmunization, especially as a supply of human source poly-anti-D is expected to diminish. Coming to the conclusion, RH isoimmunization is a real problem. People in Pondicherry with maternal fetal medicine specialists, they were able to save those fetuses. But the economic cost is so much. Prevention is always better than cure. So we should always make efforts to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain. Every woman should have her ABO RH type done at first contact. I would suggest they do in two places because there are so many places where we are giving wrong blood groups are coming. There are so many patients who come there saying positive and we do it is RH negative. So preferably you get it done in 2 labs and keep it safely. Every day, large number of women who should be protected with anti-D are not receiving anti-D. Despite postpartum anti-D immunoglobulin prophylaxis, there is a risk of isoimmunization due to the sensitizing events as explained in detail. The use of anti-D prophylaxis has reduced the risk of isoimmunization. The recommended dose, as told earlier, 28 weeks, 34 weeks, and post-delivery. And post-delivery, if you think of a high risk of fetal-maternal hemorrhage, as Madam told, we should do ICT and you repeat the dose. So I would like to conclude. Thank you.
Thank you, Radha Madhavi Madam, for stressing on the importance of anti-prophylaxis, various stages of pregnancies. Now I would like to call upon Dr. Anuradha Ma'am, President IMA Women's Wing, to give a memento and certificate to Dr. Radha Madhavi Ma'am. Thank you, ma'am.
Anu, one madam. One madam. Because
Before winding up, going for any question and answer session.
ICT should be done after giving anti-D, madam, in case we suspect more vitamin D. When is to be done, madam, after giving anti-D? Eventually. Then repeat it after 2 weeks. 2 days. 2 days. Okay. Thank you. Why would you get this? But then we expect more of vitamin nowadays. When to do ICT? I'm told no, we have to do ICT. Other anti-viral dose is enough or not. So ICT has to be done after 2 days. 2 days of giving. Antibodies 16 to 24 days depending upon the situation. Now when there is an excess of antibodies that the ICT is in this situation, then it will be coming as a positive and it will be negative.
Thank you, madams, for such a wonderful session, and thank you, delegates, for attending this session. And thank you, BSV. This is the first time we are doing a hybrid seminar, and I welcome you all for lunch. Please join us for lunch. Thank you. Before parting, we'll stand for the national anthem. जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड उत्कल गंगा इंद्र हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाये तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे Madam,